Thanks very much. So I'm going to be talking about, it's nice also I note that we're the last session of the symposium. So I hope everyone's still focusing and concentrating because it's been a long 2 days, I'm sure. And I've seen some images of the auditorium, so I'm imagining all of you there listening, hopefully. So fungi are an emerging cause of infectious complications in patients in critical care, partly because more and more patients are being taken to critical care and there are more and more interventions. Very often, the evidence base is not as good for treating fungal infections in this patient population. It's extrapolated from hematology patients. And ICU patients, of course, are not classically immunocompromised, and often their immunocompromise is transient, and also there are different risk factors to the hemato-oncology populations. And in this group, it's largely hospital-acquired infection, largely Candida, which I'm going to focus on today, but also Aspergillus and PCP are other causes of IFI in this population. So this study published in the Journal of American Medical Association in 2020 was a large one-day point prevalence studies of, you can see, over 1,000 centers in 88 countries. It didn't include Sri Lanka, but it certainly included India, looking at the prevalence of infections. So there were over 15,000 patients, and note that 70% were at least on one antimicrobial, and 9% on this single day in 2017 were on an antifungal. Of those, around half had proven or suspected infection, according to the investigators. And of those with positive microbiology, you will note here that fungi, as circled here or boxed in the red, were 16% of isolates, of which the majority were Candida, and overall azole-resistant Candida was at 1%. And you will note from this table that compared to the other infections, the ICU and hospital mortality, note 26 and 42%. So in the higher range compared to other pathogens, gram-positives and negatives. And the length of stay as well. So the length of stay, the mortality was 32 and 38%. Length of stay, 26 and 42 days. So it's one of the reasons it tends to occur late, as you know, and be associated with increased mortality, often because of underlying diseases, and higher length of stay. So Candida, as we know, colonize our gut mucosa, and also in hospitalized patients, particularly those on broad spectrum antibiotics, as we've just seen is common in ICU patients. They colonize the skin, they colonize catheters and the environment around the patient. As a result, they're between the 4th and the 6th top causes of bloodstream infections acquired in the hospital in the US and Europe. And a study called EU CAND ICU, looking at the prevalence of ICU-acquired invasive candidiasis in 9 countries in Europe and 23 ICUs, showed that there was, if you look here, there was an incidence of candidemia with intra-abdominal candidiasis of 7 per 1,000 ICU admissions. And of those, candidemia was the majority, and those with IAC alone less. And certainly in this European study, albicans was the most common cause of invasive candidiasis. In a Sri Lankan study, there was an estimated burden published a few years ago by David Denning and colleagues. It was estimated there were around 500 cases of candidemia a year, of which 60% were on the ICU. And indeed, Dr. Jayawardena referred me to an article of hers published in the bulletin of the Sri Lankan College of Microbiologists, looking at the epidemiology of invasive candidiasis between 2009 and 16. And of these predominantly invasive isolates, of which the majority were in blood and half were from ICU, in contrast to Europe and America, where albicans predominates, here non-albican species, specifically Candida tropicalis, predominated. And indeed, in this period between 2009 and 16, azole resistance had increased from 0 to 53% in Candida albicans, and in tropicalis from 6 to 17%. And this is in the context of an increasing global resistance to azoles, as well as emergence of multi-drug resistant Candida glabrata, resistant to echinocandins and azoles, particularly in US centers using a lot of echinocandins, as well as, of course, the emergence of Candida auris globally, causing, amongst others, notable outbreaks in intensive care units that were difficult to control and eradicate. So there are many different factors that make ICU patients susceptible to invasive candidiasis. I mentioned already common antibiotic use, selecting for Candida, sometimes also, particularly in the case of Candida auris, transmission from other patients and hospital equipment. Then there is, of course, a breach of skin or gut mucosa through various processes that breaches natural barriers, as well as things like lines and TPN. Then there are many different host factors, either drug-related or comorbidities that make people more susceptible, as well as some genetic predispositions. And as we know, it usually then translocates, often from the gut or sometimes from the skin, to cause a bloodstream infection, candidemia, which may disseminate to other sites, notably the heart or the eyes. Sometimes hepatosplenic candidiasis can be a feature in hemato-oncology patients. Or there can be a focused infection, intra-abdominal candidiasis being the most common inside a sterile cavity. So what about intra-abdominal candidiasis? Well, the most common cause of this is secondary peritonitis due to a barrier breach, often following surgery, or a complication of surgery, or an intra-abdominal abscess, usually from a gut or hepatobiliary or pancreatic source. In a study published between 2011 and 13, looking at countries in Southern Europe, candidemia was rare, and this is generally the case in the literature. Just 14% of patients are candidemic, hence difficulties in diagnosis. Bacterial co-infection is common, and echinocandins were the most common treating antifungals. And the 30-day mortality was 27%, so just slightly less than patients with candidemia in published studies, and an absence of source control, in other words, surgical drainage of abscesses or radiological drainage, was a risk factor. And to diagnose this, and this is one of the challenges, is we need isolation of Candida from a sterile site, such as at surgery or a freshly placed drain, as well as radiological, in our case is usually CT evidence, like in this image shown here, of an intra-abdominal infection. And then there is also the use of beta-D-glucan, which I gather from Namal is not commonly available in Sri Lanka, but we use fairly widely in the UK, and I'll talk about it in a moment. The other challenge, of course, we know as infection specialists is distinguishing colonization, which is common in the GI tract in Candida, especially in these patients on antibiotic, versus genuine infection. Also, there is a lack of evidence because most both diagnostic and treatment studies have been done in candidemia. And a bit like in candidemia, prior azole exposure is associated with azole resistance. And again, in this Southern European data, you can see in this pie chart that again, albicans was the most common cause, with glabrata being the second most common, and then paracellosis. And this is indeed the case also in the UK. These are our top 3 causes of candidemia in the UK. I won't talk a lot about invasive pulmonary aspergillosis. I just have 2 slides. But of course, in recent years, this has emerged not only as a complication of patients, hemato-oncology patients, but also severe viral respiratory failure in previously immunocompetent hosts in the context of both epithelial inflammation, damage caused by influenza or COVID-19, as well as the sort of cytokine storm syndrome associated, as shown here in this diagram, which basically means that Aspergillus, which as we know is a colonizer of human lungs, particularly the upper airways, can then translocate and either partially invade the tissue as well as become angioinvasive. And the angioinvasive stage appears to be more common in patients with influenza than COVID-19, again, providing some challenges in diagnosis. And indeed, a Dutch study showed that 19% of mechanically ventilated flu patients have influenza-associated pulmonary aspergillosis, or IAPA, and Kappa COVID-associated pulmonary aspergillosis has been reported in up to 39% of COVID patients, depending on whether it was retrospective or prospective and depending on the definition. And we have just had our own study accepted in thorax and have shown an incidence of 16%. Of course, these are different, although there are some parallels between SARS coronavirus and flu infections, there are also differences, but in both cases, steroids have been shown to be a risk factor. And there have been evolving diagnostic strategies and case definitions. But just to show you briefly data from our about to be published studies, we, like many others, have shown that the risk factors are illness for mortality, for development of Kappa, are illness severity in the ICU, pre-ICU cumulative steroid dose, the use of an IL-6 inhibitor such as tocilizumab, and importantly, pre-existing COPD. So we've seen that for Aspergillus, as David was talking about, CPA, but also COPD is a risk factor for IPA in the ICU. In our series, which was a prospective study where we collected data on antifungals, but we did some diagnostic testing on BAL and serum retrospectively at a reference laboratory. After we adjusted for confounders, we found Kappa was not associated with increased mortality, and receipt of antifungals in the small number of patients, 29 who developed Kappa, did not impact mortality. And this reflects really the challenges in diagnosis. So we used the ECMM ISHAM definition, which needs often just one mycological test, but you can see here in our series that, as in other series, serum GM was not very often positive. It just in one patient just had serum GM alone, and 9 patients were diagnosed on BAL GM, 5 on culture. But of course, as we know, particularly in the initial pandemic waves, getting a BAL and any invasive respiratory samples is challenging in this group. So we really do need better risk stratification in this group, particularly looking at, for example, pre-existing use of steroids and COPD, as well as perhaps 2 or more diagnostic tests to be positive, to really try to differentiate invasive or semi-invasive disease from just colonization, which is a particular challenge for Kappa. Now, just broadly about mycology diagnostics in the ICU, this slide was kindly shared for me by one of my colleagues, microbiology colleagues, mycologist in London. So we all know that we can use microscopy, culture, or histology, but one of the challenges in ICU patients, as I already alluded to, is the need for bronchoscopy, which certainly carried a risk of aerosolization and was a risk also for lab staff. For culture, the need for high volumes, which aren't often obtained, as we know. reduced yield in the setting of antifungals, distinguishing colonization versus infection using culture-based tests, and of course, in the case of candidemia, blood cultures which have a low sensitivity and even worse sensitivity in the case of intra-abdominal candidiasis, because often the candidemia is transient. Tissue biopsies, of course, are very challenging to get in these patients, and often this a proven diagnosis is sometimes achieved only post-mortem, certainly in the case of aspergillosis, and very few post-mortem studies of IPA in COVID-19, but these have indicated just a 2% incidence of proven IPA. So hence our reliance increasingly on non-culture-based tests. And I'm told that in Sri Lanka, the main ones available or about to be available are galactomannan, used, of course, most widely in serum and BAL, and the mannan antigen, which I personally have very little experience of, but it's certainly, there are publications on it in international guidelines. There is, of course, a new, David talked about the lateral flow for Aspergillus antibody, but there's also now IMI and OLM make a lateral flow Aspergillus antigen, which we have implemented at our center, so something worth considering if you want a sort of more rapid, easy to use, cheaper test. We all know about the cryptococcal antigen lateral flow, and there are also various molecular tests that allow us to diagnose either the pathogen, also that are used but only in a small amount of labs, and we don't have any of these available apart from PCP PCR at St George's, where I work in London, a teaching hospital. But these are increasingly coming in for diagnosis, and certainly Aspergillus PCR can be useful in combination with galactomannan, and there have been many studies published on the combination of the two, again, more in hematology oncology, but the PCR comes into the kappa and IAPA case definitions. The beta-D-glucan is a useful so-called pan-fungal marker, which may be useful for invasive candidiasis screening in the ICU, and I will talk about this more, and as a tool to antifungal stewardship. However, the challenge is, I'm sure for you, but also for us here in the UK, is do the clinicians use it correctly? Is it available? What's the turnaround time? For example, we still send away our beta-D-glucan to Bristol, and it takes a week or more to get a result. And of course, these tests, particularly the molecular tests, require laboratory local expertise, as well as sufficient tests to make it worthwhile to introduce it in-house. So what about beta-D-glucan? Well, this is an antigen that's present in the cell wall of Candida aspergillus, also Pneumocystis and Fusarium. The most widely used kit is the Fungitel assay with a cutoff of 80. There's also the Waco test, which we're validating currently for introduction in our lab, which is more cost effective if you're thinking of small numbers of samples. So its roles could be, and it is being used in the ICU to assist rapid diagnosis, but actually probably a better niche for it is to assist exclusion of IC. Why? Because it has a much better negative predictive value in the order of 90 to 95%, whereas a single test, certainly for the Fungitel of over 80, has a very low positive predictive value. And could it be used to monitor treatment response? Well, its dynamics, we're currently studying them in patients with candidemia. However, again, like cryptococcal antigen, it persists for quite a while. So maybe it will be helpful, but it will need many sampling, and it might just be used in clinical trials. We all know there are many things that can cause false positive tests, including things that, of course, is common in patients on the ICU. And the performance is improved by having 2 consecutive positive samples, increasing the positive threshold to greater than 250 for the Fungitel, or combining with other markers. And I guess if you are introducing mannan, it'd be interesting to hear whether you're thinking of introducing any other tests. And we don't have in the UK the germ tube antibody. Very few centres have the T2MR, just one centre in London uses it, and procalcitonin is another marker that's used in some ICUs, a marker of bacterial infection. A panel of European and American intensivists and infection specialists tried to get together, because we know that the EORTC criteria don't apply very well to fungal infection on ICU. So you can see here that the Proven IC was not a difficult consensus to reach, but they struggled to actually come up. These are some proposed definitions for probable invasive candidiasis. Note in bold, I've put additional host factors which are different to the EORTC criteria, including candida colonization and impaired gut wall integrity. And then note under mycological criteria, there are these two consecutive positive 1,3-beta DG, as well as candida from a intra-abdominal sterile specimen, as well as a clinical criterion. So those were the proposed definitions published in 2021. Just to remind ourselves in terms of antifungal therapy, I'm sure you all know this, but of course most of the antifungals are cell wall acting, with only flucytosine acting in the nucleus. And polyenes are broadly fungicidal. Azoles are, of course, static against yeasts, including Candida and Cryptococcus, but cidal, voriconazole and posaconazole against molds. And echinocandins, our first line, are the fungicidal drugs against Candida, but of course are fungistatic in terms of their mode of action against Aspergillus. And flucytosine is useful as an adjunctive therapy, both in Cryptococcus and is underutilized also in treatment of Candida. And this could be quite a useful second drug to bear in mind with increasing reports of azole resistant. So both European and US guidelines recommend echinocandin as the first line based on its cidal activity and superior performance compared to fluconazole in clinical trials. De-escalation after 7 to 10 days, depending on the guideline. Treat from 14 days from negative culture and do daily blood cultures as well as ocular exam and echocardiography to document clearance and to look for metastatic infection. However, in the ICU patient, there's this de-escalation to fluconazole. I'd be interested to know what you use in your ICUs, but there is certainly some evidence that we are underdosing fluconazole, certainly in terms of guidelines saying 400 or even 800 patients. We often find on our stewardship rounds that patients are just on 400, and there is quite a lot of data to show that this is not going to be reliably attaining the AUC over MIC ratio, and that particularly those who are obese or have a higher creatinine clearance or are on renal replacement therapy. So it's worth just bearing in mind and adjusting doses up. And I have to say my tendency is to use 800 or even 1200, which has been our experience to use safely in cryptococcal meningitis in patients with candidemia that's susceptible to fluconazole when de-escalating, or if you don't have echinocandins available. Now, the other issue, of course, we know we have to consider is biofilm, and this is an in vitro study looking at the activity against Candida albicans biofilm of, you can see that fluconazole really doesn't have good anti-biofilm activity. And this is another reason why echinocandins or even amphotericin as an alternative are preferred in the case of line-related infections or heart valves, urinary catheters. And indeed, source control, as I've already mentioned, is a hugely important aspect of management as well as antifungals, with this study from Spain and Italy showing that patients who don't receive adequate source control have a worse outcome than those just receiving antifungal therapy as well as source control. So this is, of course, important, whether it's line removal or whether it's drainage of that intra-abdominal collection. And I'm sure you, as microbiologists rounding on your ICUs, are very good at encouraging your colleagues to change those lines or drain the pus from the abscesses. Of course, I've just talked here about targeted prescribing, which is directed at a known fungal infection, but what about all the other prescribing that goes on in the ICU? We know that a lot of prescribing is prophylaxis, but particularly in this group, that empiric prescribing is very common. In fact, probably the most common that many studies have shown. And this is just directing it at a patient with suspected but not confirmed through any biomarkers or culture-based tests, fungal infections. So in our own audit of prescribing across 3 London ICUs pre-pandemic, you can see here that empirical prescribing was by far and away the most common, with an echinocandin and fluconazole being equally used in this group. And what was this directed at, as shown here on the right? Either a suspected gastrointestinal or abdominal source, unknown source, or aspergillosis in some cases as well for this empiric prescribing. So the most common mode of prescribing in our setting is empiric, and that's what I spend my stewardship rounds discussing with my colleagues. And this is, of course, the dilemma. We know from the literature that delays in appropriate therapy are associated with worse outcomes. However, if we are overprescribing, and there's a lot of literature to suggest that we risk, as we already have shown, increasing resistance, excess toxicities, and cost. So what does the European task force that have recently published recommendations on practical management? Well, everyone is recommending that we should use risk prediction models, but how do we use them and what's the evidence? So as you probably know, for some years now, we've had Candida colonization index, where you look at the proportion of colonized site, again, excellent negative predictive value, or the Candida score, which incorporates both colonization and risk factors. And then there's this clinical prediction rule as well. Again, note, PPV, a bit like with beta-D-glucan, poor, NPV, good. So these things are good at excluding infection. So what do our intensive care colleagues recommend? And we use something fairly similar to this adapted at St. George's. And of course, it depends what biomarkers and diagnostics you have available. But if you have a septic patient on antibiotics not responding, depending on whether you think it's an abdominal focus or not, you start empiric antifungal therapy. It's echinocandins that are recommended in Europe and the States. You look at your risk score for the candidemia group, and then you send off a beta-D-glucan. If it's negative, you stop early. If it's positive, particularly high-level positive and perhaps a second biomarker positive, you continue, but you always re-evaluate post-prescription. And I do a lot of stopping of therapy, and this is why I'm trying to bring beta-D-glucan in-house now, because I don't have a result by day 7 to help me stop early, and I'm hoping by bringing it in-house, I will have this. What about evidence for use of empirical treatment? This is the largest trial done to date using micafungin in critically ill patients with ICU-acquired sepsis and multiple candida colonization, and also evidence of organ failure. And you can see here, and one could argue that this was underpowered, and the main endpoint was fungal infection-free survival. Micafungin did have an improved survival, but this was not statistically significant for this patient group, and micafungin was more effective at preventing new invasive fungal infection. Of course, penetration is another factor that's key, as we know, as infection specialists, and this varies across the spectrum. So, of course, we know that, for example, fluconazole and voriconazole are better at CNS and eye penetration, whereas we wouldn't use echinocandins. And for intra-abdominal penetration, then the echinocandins may not have such a good, some of the echinocandins don't have as great penetration as perhaps things like fluconazole. So this, of course, is also important, getting to the site of infection. And this is just my last slide, and I know this is a busy diagram, but I just found it in a relatively recent publication, but there is some suggestion that it is particularly in the intra-abdominal compartment where echinocandin resistance is beginning to evolve. Why? Because they have poor penetration into ascites and peritoneal fluid, high penetration in the tissues, but not so much into the fluid. And in fact, two publications, one from the States and one from a Spanish study, showed that in patients with intra-abdominal candidiasis, albeit exposed to a very long course of echinocandins, which is not certainly what I would use in my practice, a quarter developed FKS mutations, so mutations in the beta-D-glucan synthase gene. And in the Spanish study, looking at over 1,000 candida isolates, they were able to show over time in patients, and these are just 6 patients on the ICU, shown over a time course, and azoles are shown in green, and echinocandins in blue, and you can see here the Rs are resistant. So the initial blood cultures were very often sensitive. So if we just look at our initial blood culture isolate, we underestimate resistance. Whereas when they looked at the incident abdominal cavity isolates, they reported a higher rate of resistance. So they discuss about compartmentalization, but really it's a timeline, and this is something we're looking at as well. And of course, the longer the exposure and the later the specimen is, and that's why we do need to be testing subsequent specimens and speciating and testing these candidas, particularly from the abdominal cavity, to look for resistance, because if we just look at it in the initial isolate, we will underestimate that. So lastly, this is just a table which I'll leave you to read yourself, but there are so many factors to consider when we're directing antifungal prescribing for patients on the ICU, including the local epi, previous exposure, colonization, the site of infection, the drug interactions, other organ failures or supports, and of course, TDM. So I hope I've given you a bit of an overview. It's been a gallop through, and I'm very happy to take any questions. Thank you.